Can you hear me?
Yes.
Cool. We'll see how many people we get today. Power's been out here. Commissioner's here. Linda's here. Lisa, Monica, Amber, Jill, Linda Whitney, Amanda. Who else we got up here? Okay, we'll wait a couple more minutes here. How's everything up in Astoria? Pretty nasty down here.
It's not
It
too
was
bad
kind of
up
windy.
here.
Yeah, but now looking out the window, the tree's like barely moving now. So
Yeah, we got a tree down on Wahana and 13th, and it's closed. I am going to go ahead. Let's go ahead and get this going. Lisa, we recording automatically?
yes, and so I don't know if we have quorum. Maybe
We don't
okay.
yet. Yep,
Yeah.
that's why I was waiting for a couple minutes, but
Okay.
at this point, we do not have a quorum.
Okay.
So let's go ahead, get the meeting going here. We can go through the meeting. Without a quorum, we just can't vote on anything. So, okay, I'm here. Valerie said she will be late getting in, so she should be coming on here pretty quickly. Linda Winstanley, you're here. Julia, I don't see Julia yet. I don't see Grant either. Linda Whitney, I see you. You're here. Miranda is an excused absence today. She will not be with us. Amber, I see you. And Seamus has an excused absence as well. So right now we only have 4 out of 8 here.
Grant is coming on right now.
Grant's coming on? Okay.
Can you hear me?
Grant? Yes, I do. Okay, that gives us a quorum right there. Perfect. Okay. Commissioner Thompson, you're here. I see you. Jill Quackenbush, I see you're here as well. Lisa's here. Monica, I see Monica is here as well. Shira, is she here or is this Amanda filling in for Shira? Okay, Amanda's here. Okay, let's move on to
Randy, this is Valerie. I just got on. I was having trouble.
Okay, perfect. Valerie's here too. Perfect.
And Randy, I'm here too. This is Julia.
And Julia's here. Perfect. Okay, we got everybody here. Except for Miranda. Miranda has an excused absence. All right, so let's move on to approval of the agenda. Before we start, I have an addition I would like to make to the agenda. And I would like to put this under old business. And what we got here is we got the old business A, we have Care Oregon policy update. I would like to add a B onto that. And that would be Amber Bowman was not at our last meeting due to she's watched the minutes on the YouTube channel from that last meeting, and she has some things to say about that last meeting. So I'm going to give her a chance to do that. So I want to add her on for a presentation, old business B, Amber Bowman presentation, and I'm going to allow her upwards of 30 minutes if needed for her presentation, what she has to say, and if there's any questions, feedback, or whatnot on that. And that is all that I have for that. So does anybody else have any additions to the agenda that they would like? If not, then I would like to get a motion to approve the agenda with the added item.
I'll move that we approve the agenda with the added item.
Okay, I need a second, please.
I'll second.
I'll second it. This is Valerie.
Perfect. Okay, motion has passed to approve the agenda with the added item. And public comments, we'll move to that. I don't think we have anybody from the public. Let's move on to presentation, Youth Prevention Needs Assessment. Lisa, you have the floor.
All right, let me share my screen. Okay, are you guys seeing the presentation?
Yes.
Okay, I can't see you anymore. So please speak up if there's anything that that you'd like to say along the way. It's fine to ask questions as we go through this. It didn't start at the beginning. I'm sorry, a little bit of there we go. Okay. So we have been working on the Youth Prevention Needs Assessment through our tobacco and alcohol and other drug overdose and problem gambling prevention programs. So I wanted to, now we finished it up. We just presented to the Board of County Commissioners with Heidi Bertu, who was our contractor for this prevention project, assessment project. So I wanted to present what we found. So just to kind of set the stage for prevention, because it is a science and there's some very specific definitions and frameworks that are used around it. This framework is kind of the levels of prevention that public health uses. It's a very old framework. It's been around a long time. They recently in House Bill 3321 defined what primary prevention is, and that's kind of the base of this pyramid. So primary prevention is practices, programs, and policies designed to prevent, delay, and reduce the incidence and prevalence of youth substance use. And then as you go up on the triangle, there's secondary prevention, which is after someone might have a disease, but they aren't experiencing the signs and symptoms yet of that disease because of that disease. And then there's tertiary, which is preventing the long-term effects of the disease. So the reason why primary prevention is the base is because if you can do those kind of wide strokes of helping people, preventing people from starting to use or reducing their use in substances, you're gonna reach kind of the biggest chunk of people doing that. And then as you move up to secondary and tertiary prevention, you're really focusing on smaller groups, or a lot of the time tertiary prevention is working with individuals. So one of the models that's used really frequently also and is used more now is this Academy of Medicine. They used to be the Institute of Medicine, so a lot of the time it's referred to as IOM, but they are now the Academy of Medicine Continuum of Care. So this is supposed to be all of the things that you should have, all the types of activities you should have or programs in a community in order to really meet the needs around. It was specifically designed around substance use as well, and to help community partners tell like what are the things that we're doing and who should we be coordinating with, because they might be doing another slice of this pie. So it starts with promotion, but sometimes that's kind of at the bottom, because in all of these strategies, you should be promoting people to have make healthier choices in their life, regardless of what kinds of services they might be needing or accessing on this continuum. So universal prevention is prevention strategies that are aimed at the general public or a whole population group without identifying individuals who are at a particular risk of developing substance use disorder. So that is also from House Bill 3321. So it's kind of for this model, prevention is primary prevention. And now they're defining the 3 different pie slices or types of primary prevention that there are. Then there's selective prevention, which is focusing more on specific groups or individuals who are at a higher risk of substance use disorder. And so an example of this could be working with folks who have, been exposed to more trauma. And so that puts them at a higher risk of of eventually someday developing substance use disorder. And then indicated are prevention strategies that focus on individuals who are exhibiting early signs of substance use or have other risk factors, but who have not yet been diagnosed with substance use disorder. So a good example of this would be, doing when there's the screenings that you have at the doctor's office, or if a student was seen to be violating a policy for drug or alcohol on school campus, and there's specific interventions that the school decides to do with that student. And this can tip over into case identification. They might be referred to get further assessment, and it might be found that they do have substance use disorder, and what they need is treatment, not prevention. So it's important to be knowing who, what it is that you're doing and what it is that other organizations and people are doing in our community, so that you can be coordinating across that continuum of care. So we decided to conduct this youth prevention needs assessment because we really wanted to know what is the problem and what are the community needs, or what do they want in order to address the problem. So we did this by gathering data and exploring factors and identifying themes. And so this helps us understand specifically what the issue is that needs to be addressed, and so that later we can design programs and form partnerships that are going to help address the needs that are identified in this assessment. And we also, in the assessment, really tried to engage with the whole community in diverse locations and ethnicities and languages. And so ultimately, we're hoping this will improve the health system for youth and families around how we as a community respond to substance use disorder. And it also, we have to have this assessment kind of as a baseline in order to be able to evaluate later how it is that some of the interventions that we decide to implement have done. So the types of data that we gathered and used in this assessment were both quantitative and qualitative. Quantitative is like percentages and ratios and counts and surveys. So we did an educator survey that we partnered with CBH for, and we asked questions that would be helpful to this specific prevention assessment, and also would be helpful, hopefully, to CBH in them implementing their current programs around treatment and recovery, and their peer specialists that they have working at, or they're beginning to have work at the schools. So we shared the development of that survey with them, and then shared the results. We also looked at the student health survey, which is a survey that's done every 2 years in all of Oregon, and schools decide if they want to opt in or opt out. And we had over 200 students in each grade. It's done in 6th, 8th, and 11th, and we focused on 8th and 11th, and we had over 200 students in both 8th and 11th grade, each that participated in that survey. So then we were able to look at the results of that survey as well. And we looked at census data, and we looked at other statewide health indicator data also. For the qualitative data, that was where we went out and we did key informant interviews. We did focus groups with youth and parents and teachers and youth serving organizations and other people who work with youth. We had 16 community leader interviews. We had 5 youth focused focus groups, and we had 2 adult focus groups that were a part of this. And this part is where we really leaned on the and in the quantitative as well, but we really leaned on the expertise of our contractors who helped us perform these interviews, and they're also a neutral party, and so that allowed the people who are the key informant interviews. Sometimes we were present, some staff members were present in those key informant interviews, and we made sure to have someone in the focus groups, but it was really being led by this neutral party, which was nice. And then they also helped pull out the themes as a neutral third party. So what did we learn? The themes that came out of the data that was analyzed was communication and education, mental health support, social environment, and community resources as the important kind of areas that we should be focusing our prevention efforts on. Specifically, communication and education was the strongest theme that was identified from the data that was analyzed. So this is from the focus group. So we also had little worksheets that kids did in the focus groups where they could write kind of things down, and between what was written and what was said, it was identified that youth are getting a lot of their information from, or the most from social media of the youth that we spoke with as part of this assessment. And some of the specific themes that came out of the communication was that they were getting confusing messaging from adults. This was specifically from youth. Prevention education wasn't always working well, and youth avoid reaching out for help for fear of judgment or getting in trouble. From adults, which included parents, the prevention strategies based on fear weren't working well, was one of the things that came out of the information they shared. Cultural taboos sometimes make it hard to talk openly about substance use. There wasn't enough consistent education about the dangers of substance use, and families often don't discuss substance use enough, which can increase the risk of problems. So when we did the focus group with educators and did the survey, educators were saying that there was not very much parental involvement in prevention efforts, and that not very many people attend community events or talk about substance use on a regular basis. And then schools, government agencies, community groups, they don't always work closely together, which leaves gaps in supports for the support that can be offered to youth. And only 7 to 9% of school staff felt that they had enough training to handle substance use problems. Most staff reported having little to no training on how to recognize or deal with student substance use. And then staff reported that they lacked confidence in key prevention approaches, which is what this chart is here. This was from the survey. That's parental involvement, like, youth and students teaching and helping share information with other students, which would be peer-based teaching, and having guest educators and evidence-based curriculum. You can see that the tan bar on this chart, which is the not confident, is pretty big for each of those sections.
Lisa, this is Linda. I've got a question
Yeah.
on the prior slide. So I'm just, so explain like parental involvement, not confident. What does that mean, and where'd you get that information?
So this was a question that was on the educator survey that we sent out, that was filled out by staff from all the different school districts. And specifically by parental involvement, that's like a teaching technique where you're not just teaching the students, but you're also having, like for the My Future, My Choice, which is this sexual health education program, they also have a couple of times where there's a worksheet that you send home for the student to do with their parents. And so that would be parental involvement. Or from the other information that came out, potentially from the focus groups and the theme details that were shared by our contractor, it sounds like potentially in some of the focus group, parental involvement could also look like, well, how do we get parents to come to this other community event that we specifically set up, where we want to talk about substance use with parents, the same, so that they're receiving complementary information to the information we're sharing in class with students.
Okay, thank you.
Yeah, sure. So This is from the student health survey. So specifically eighth graders, there was 294 eighth graders that filled out this survey, and there were 243, and that was across Clatsop County, not broken down by specific school districts. But you can see that the bars are much higher, the percentages are much higher for 11th grade than 8th grade. You can see the highest bar is between 30 and 35%. So we're still not talking about, the majority of students who have ever tried this substance. And when we start doing our planning phase, we're also going to dig in and look at what students have used a substance in the last 30 days. We'll include tobacco, which was included in this assessment, but just not in this chart. To see like what youth are really doing and use those numbers to inform what our planning will be as well. But this is kind of a good baseline that you can see the numbers go up from 8th to 11th grade. And so if we start before 8th grade with specifically talking about substances with youth, and then you start even before that with building all the other factors that youth need in their life in order to be confident and have the skills that they need to be successful, which helps them is in itself prevention from using substances. All that is important to be doing it, starting younger and then continuing all the way through, because we want to make sure that we're providing that probably more indicated prevention for the youth who are using substances at older grades, and then continuing to really bolster the confidence in the youth in those later grades that are not using substances.
Lisa, I
So,
see Linda,
yeah.
Linda has her hand up.
Oh,
Sorry.
thank you.
You talked about tobacco.
Mhm.
Did you do the research on tobacco and just not put it on here, or did you not do the research?
We do have the numbers on tobacco, and we didn't put it on here because it was getting to be too many. We kind of went back and forth, and it was just getting to be a lot of different bars. And so we do have that. And when we talked about substances through all of our focus groups and key informant interviews and the survey with educators, tobacco was specifically called out in those. And so you'll see other places in our report where we do talk about tobacco. And when we do start planning, then tobacco will be included equally. So, and I could get you those numbers as well if you would like them.
Yeah, I would like to know where that falls.
Yeah.
Thank you.
Yeah, no problem.
Commissioner Thompson has her hand raised as well.
Well, this was such a great presentation. And now that I've had a day to think about it, it's been percolating. I keep thinking, wow, what can the Board of County Commissioners do? What can this committee do? Who's got the scope of authority? Who can do what to move this forward, to lift it up and to use it to make a difference? So I don't know what the answers are, but I'll tell you, I'm really fired up and interested in doing what we can to make use of these data to make a difference in our community. So I just want to pin that right now.
Thank you. Yeah, I appreciate that. And next I'm going to talk about like the rest of our process that we're planning on going through after this. And the next step is capacity building. And that is the question that we need to ask ourselves and our community partners, and really figure out like what our capacity is as a community to be able to do some work. So I'll talk about that on the next slide, and it's a really good question. So what was identified in this that was kind of brought up that what all the people we talked to thought would work to address this issue is that adults being open and honest about their personal experiences and sending clear, consistent messages, no matter who they are and who it is that they're talking to. And that would probably include parent education, because that's a tough topic, as we've identified in this survey, to figure out how to navigate with young people. And then education materials that are current and include discussions that are open and flexible and encourage sharing ideas and resources. And that could look like that peer-led model where you have youth who are the ones who are facilitating the education and the conversations with each other. And then culturally relevant content is also really important when we're thinking about serving all the youth in our community. So the process, to talk more about what Commissioner Thompson was talking about. So we've done the assessment. There is a strategic prevention framework, which is what what SAMHSA uses, the Substance Abuse Mental Health Services Administration has developed, and it's kind of like the gold standard for how you do prevention science. So we've done the assessment. Now we're moving into capacity building, and that's asking the question, what resources will we have? So in this part, you want to strengthen the community resources, and you want to share this. It's kind of going on a roadshow and sharing this specific assessment we've done, so that people understand what it is that the community is saying that they need and what the problems are, so that we can raise the level of readiness of the community to commit to working on prevention. And then it also, the next phase after that is planning. And that's asking the question, what should we do? And we want to make sure that in that planning phase, we're not just doing that all by ourselves in public health, because we know that there are lots of other organizations that are either doing prevention or are interested in doing prevention. And we want to make sure that we're supporting each other to maximize and create the most capacity and to address the problem. We're coordinating with each other in our planning process. So I'm going to invite all those organizations in to do the planning with us. We're hoping to present next month at the superintendent's meeting, and I'll invite the school community into that planning process, and we've already been in a meeting talking with the harbor, with their prevention folks. And there's lots of other great organizations that are doing prevention work that we would want to make sure we were talking to and planning with for that part. Another piece of planning that's really important is across the blue petal across from it, evaluation. We want to come up with how it is that we are going to measure how successful our implementation is. So we'll figure all that out in planning, then we will implement as a community the strategies that we've planned for, and then we'll evaluate how they're doing, and then that evaluation leads right back into assessment. So we'll just keep going around to make sure that we're being responsive as our community changes and grows to what it is that they need.
Lisa, Amber Bowman has her hand raised.
Go ahead, Amber.
Thank you. I was just wondering, you're talking about the planning stage. Are like CMH and Providence, like healthcare included? And then I'm just wondering if they're part of that planning process.
So CMH and Providence, they definitely do prevention, but when I think of the type of prevention that they do, I think of it more of preventing chronic disease. They do lots of screenings. And so while I think that it would be very beneficial for us to plan with potentially like their pediatricians, and I would absolutely welcome that, it had not come to mind for me to specifically request that. And so I will put that on my list of organizations who I should reach out to. And we are connected through the Rural Health Coalition with them. And so I think that's a great idea. Thank you.
Absolutely. The reason that came to mind is because my sister is a nurse at Providence, and when she was getting her bachelor's, she actually wrote a paper about a youth peer support substance abuse, and had the framework for it and everything. And she had taken it to someone at Providence who was really excited about potentially rolling it out. And so that's
Awesome.
why it came to mind. So
Yeah. Thank you. Yeah, there's probably a lot of opportunity that I have not even thought of places where we could be partnering and we could be expanding our capacity as a community, because there's organizations who are doing things or interested in doing things that I'm not even aware of. So, and really, I mean, all the work that having access to medical care, low barrier medical care, and mental health, and parenting classes, and responsive school districts, all of that is prevention, without whether you are talking about substance use or not. So there's a lot of people doing really important work. So just one word about evidence-based. So this is directly from SAMHSA's focus on prevention. Substance use issues are too serious and resources are too valuable to take a chance on unproven prevention strategies. To get it right the first time, choose a prevention strategy that has been shown through solid research to produce results like the ones you want to achieve. So this is the reason why we use this strategic prevention framework. It's the reason why we look at the databases of, research and that's already been done that's shown that something is effective. And we try to use those frameworks that we know work to identify in the planning phase what kind of strategies we should be using, and then to follow through and evaluate them at the end. So that is my presentation. Let me end does anyone want me to go back to any slide before I end my presentation? Okay.
Amber has her hand raised again.
Oh, go ahead, Amber.
I just have a quick question about the surveys that you took or that you based all this on. Were there any populations that were underrepresented in that data? And is there a plan to get more information or get more data from those populations?
Yeah, there was some school districts that weren't able to or didn't have capacity to participate as much. And I think that there's going to be kind of and we're going to continue to engage with those school districts to make sure that we are offering them the opportunities to come and be, can we present on this to them? Can we include you in our planning process? Can we offer you these strategies that we've come up with in our plan? But if right now they're not at a place to engage, then we'll be potentially piloting some of these with other school districts that are able to engage more with us, and then we'll just keep circling back around to make sure that we're not excluding them. Jill?
I just also wanted to say that our contractor also had the ability to do focus groups in Spanish. So we do have the inclusion of our Spanish-speaking residents as well.
Thank you first. I should have specified that one. Thanks.
Okay, any other questions or comments for Lisa? Okay,
I just want to
if
add real
not-
quick. Oh,
Oh.
sorry, Randy. I just
Go
want to
ahead.
add real quick that I want to piggyback on Commissioner Thompson's excitement about this data, and the presentation, Lisa, was awesome, and all this information just made me feel like fired up and like, what can I do and how can I help? And so thank you for doing this.
Thank you. Yeah, that means that potentially the capacity building is succeeded, because that's how we want you to feel. So, yeah.
Okay. All right. Yes. Great job, Lisa. Thank you. All right. Let's move on then. If there's no more questions or comments for Lisa, let's move on to new business and membership applications. So we have, first off, we have an applicant that, and it was at the same time that there was several other applicants like Linda and Miranda and a couple other people. And then Linda Dugan and myself, and I believe Julia, were reapplying applicants. I weeded through, I interviewed this person. His name is Nicholas Bowling. And Grant, sorry I didn't get back to you. And I thought you had been on that with me and interviewing him, but I went back and reviewed the YouTube channel. Just me that interviewed him. And so you all should have you should have his application attached. Lisa attached it to one of the communications. So you should have had that a few months ago. And at this point in time, I'm going to go ahead and recommend that we accept him. comments or questions with that? If not, then maybe I can get a motion to approve to pass this along to the Board of Commissioners to look at.
I'll make that motion.
oh.
This is Valerie.
Okay, we have a motion. Need a second?
I will second.
And we have a second. So we'll pass that along. Have another applicant, Glenn Maynard. And Lisa let me know that he's very qualified, but he is a current paid position with CBH, so that disqualifies him. And that's all I got for that. So any questions, comments? Okay, let's move on. Old business. Old business A, Care Policy Oregon, or policy update. Care Oregon is unavailable to present and encourage all those interested to listen to the presentation. Reach out to Care Oregon directly to discuss anything pertaining to their clients. Lisa or Monica, would you like to comment on this?
Before we break into it, I just wanted to point out that Christy just joined, so she's also in the meeting now.
Okay, perfect. Welcome, Christy.
I have a question on this, Randy. Did you guys contact the CCO as well, or just Care Oregon?
We contacted Care Oregon, or I'm sorry, the CPCCO, Columbia Pacific CPCCO.
And so Columbia Pacific didn't want to present
They
either?
presented at the board to the board, and so they're not looking to go and talk to individual groups. They presented as a favor to the board, and so that's all that we can do is ask them.
Because I know when I was at that Oregon Health Authority meeting, the Ombudsman office was there presenting, and I sent out the email, and they're very aware of the the mental health provider issue, and so they said first line of contact was the CCO, and if we weren't satisfied with the response there, to call the Ombudsman office. So I didn't know if the CCO wanted to comment on that, or we just go through the process as we see fit. I guess we go through the process as we see fit.
Process, yeah.
Since you don't want to come on.
That's
okay.
That's what I'm thinking.
Okay.
Amber.
Okay.
Amber has her hand up.
Yeah, I was just curious if the request to the CCO was specifically for them to come present to help clear up the misunderstanding about the number of youth impacted in our community. Like, was that specifically mentioned to them, or was it just, we just want you guys to come repeat what you said already to
No,
us?
we specifically asked, and I thought that got emailed out. We specifically asked them about that question, and that was a point in time. So when they're pulling data, they're just getting data at that point in time in regard to how many particular youth that you're talking about at that point in time. So that is an ever-changing number based on what is being submitted for claim reimbursement. And so it's a static number, but it is a number that is going to constantly change.
Yeah, and I apologize. I think that direct response I might have only shared with Randy. And so I'll find the exact wording of what they said. And then when I do, I can share that out with you guys as well. And for Ombudsman, I also, I haven't worked with them a lot, but the times that I have, it was they investigated like specific, it wasn't like they might identify a systemic problem and give feedback, but they really want to hear the specific examples. And so it's like for us, when working with WIC, when I was a WIC certifier, they wanted me to have a specific case of something that was not working and to reach out to the Ombudsman to talk about that. So that is definitely a good resource for providers and their specific cases. And it might help identify something that's systemic that then they can also advocate for, but they'll advocate for the individuals is how I understand their place to be.
Yeah, Lisa, that's right, because I've used them quite a bit too. And it's for the individual, and they're really proactive. So that's why it's best for us to go to the CCO first, so we have the information. Because you're right, they're very proactive. When you contact them, I mean, I don't know how overwhelmed they are right now, but whenever I've contacted them, they've been right on it. Yeah, they're very
Yeah, they're a
good.
great resource.
Good to
Yeah.
know. Good to know. All right. Thanks, Linda. Any other questions or comments? Okay.
I'm curious, Randy, I'm curious that, so if it was a specific date and time that that data was from, is there a way for them to, now that the change has gone, to give us a new number that they think it's the number of children that are being impacted in Clatsop County?
I would imagine based on the
Question.
response that they gave, that that's gonna change every month. And so that would be asking for them to update that number every month, because again, it's based on the claims being submitted. But Lisa can.
That would be fine, but I'm just really curious, the number that, not every month, but the one from the month before, or whatever that date was, to the a month after that change was made, to see how many less claims there were for children. The number of children that are, which would indicate somewhat the number of children who are now getting services, not getting services in Clatsop County.
Yeah, Lisa, when you find that language, if you could pull it up and I can follow up and see if they can research that data.
Yeah, I found it and I'll send it out. It says, we heard from the CPCCO. The member data is from claims that were pulled at a specific point in time. The numbers aren't static because of the nature of claims submission. Due to that and the limits claims data presents, the CPCCO would encourage HSAC not to get stuck on that specific number.
Which is fine, but that number was from before the date of the change. So the presentation was before the change.
Yeah, if I may real quick, I think what Julia and I like, and this is in my presentation that I'm going to give here shortly, but we have a different perspective from the work that we do. And one of the concerns is, we're wanting the county to be able to understand the damage, for lack of a better word, that's being done. And we don't feel like the presentation gave an accurate view of that. And so what would make sense is the data for September, for claims submitted in September, what those looked like, because that was right before that October 1st policy change, because that might be more accurate. So, and yeah, anyway.
Before and after.
Well, and the after would be interesting as well, yeah.
Because that, when we were hearing that data, that's when we were having to tell clients we couldn't see them anymore. And so we knew there was no way they had that number yet, because it was before the October 1st. Just a concern, huge.
So I want to write this down, right? So we want the data. So it could be even that this specific data that they're presenting isn't the data that's going to get to that. And so really the core of it is we want to know if there's any data they could show from before and after that would show what the impact has been on. Is it specifically on a specific age range that you're looking for?
Well, it's all county members, but for Amber and I, being very few therapists that work with children and knowing the other ones, we know that number is way bigger.
Okay, so specifically children. Okay.
I think all the numbers could be interesting because they're still county members, and it's not because CBH isn't doing the best job they can. It's just because the private practice therapists were serving an important need in this community too. And CBH can only see so many people. I know they're doing the best they can, but when we say call CBH, they say the wait time is very far out or get different answers.
But Julia and Amber, if you guys, one of the ways to affect change is if that happens, call the CCO, and if they don't help, call the ombudsman office. I mean, that's all just another avenue.
When I've tried to work with the ombudsman office, they work with, they don't work with therapists. They work with clients, like you said, your clients.
Right. And so that's putting the burden on the client to advocate for themselves. And when you're looking at some of these families, they don't have the resources or the capacity to do that. And I would love to sit down with every one of them and make that phone call with them, but I just don't have that time. So yeah, that is a frustrating thing because the ombudsman sounds like a really great option, but I've had the same thing that Julia reported, is that they don't work with the provider. They work with the family, with the client.
Okay.
And if
Commissioner Thompson?
Thank you, sir. What I'm interested here as a commissioner who is active at the state level and talks to a variety of people is having data. Understanding that the provider, there are going to be issues, but data is data. It seems like a fair ask of CBH and of the CCO. There should not be a problem getting program data because it makes sense to me that they're reporting that data already to somebody. We're asking to share data, not create new data. And what we're looking for is a community awareness of what's going on in our community so that that information can be communicated through a variety of channels. I mean, I love the idea that Linda has, that there's an ombudsman who can work with people who are capable of advocating for themselves. It also makes sense to me that the Board of County Commissioners is by law the mental health board, the mental health authority in this county. And when there were some legislative changes that impacted that, we still have some authority in that regard, and we're elected to represent the needs of the people in this county. Data help us do that. So I just want to support every data request and say that I think it is a reasonable and appropriate and necessary thing to do, to have data. Thank you.
They also
Okay.
have a dashboard, and I will look at the dashboard, and I'm looking for my link to it right now. And if I see anything that's already on there that might be of interest to you guys, then I'll let you know. And like you said, if it's already data that they have and is available to be able to look at what you're asking, then it might be available already there.
Commissioner Thompson, do you still have your hand up? Do you have another comment? Okay. All right. Any other comments or questions? Well, Amber
I did see
Bowman.
Amanda's, sorry, I've just real quick.
Oh,
I did see Amanda's hand
okay.
up earlier. So I just wanted to check back with
Okay.
her and see if she had a question or comment.
Amanda.
Yeah, I was just thinking about like what kind of data the CCO can actually get that's accurate from just membership, because you also have to take into consideration how many cases are legitimately closed, how many kids move out of county, how many are moved to higher levels of care, and that all impacts like membership payouts if that's the numbers are going off of.
We're not asking for membership, we're asking for claims.
Well, that's what I'm saying. It affects like what claims they're processing, right? Because those claims will stop when those events happen. So they're going to have to look at like a well-rounded view of like what's actually occurring when they give you information back.
That number probably doesn't change a lot from month to month, the people that leave that insurance. But so just number of claims would be a good number to give us an idea, a good enough idea.
So Julia, I've got a question. What do you plan to do with the data? What are you hoping to accomplish?
We just
with
want
the
people to
data?
be aware of how many people, children especially, but people in general, lost access to mental health therapy with the change that OHP made.
Because I know there's another county that they were talking about that like 45% of the people that were accessing care are going to lose that access. So I know the state's aware of it. And that's why I was hoping there were other ways to
We're really looking
provider.
we're looking specifically at mental health care. I know that the whole thing is an issue. Yeah.
And that's what they were saying. One county was losing because they were using so many providers outside of their CCO that they were. So I think the state is aware of that, but how are we going to solve that? I guess is what. So you're hoping if they're more aware of it, they might go back to the licensed providers using them.
Private practice. Yeah, everyone has
Private
to
practice.
be licensed, but private.
Yeah.
Practice. Yeah.
Okay.
And wait, I want to just say one more thing. It's out of network private practice. They do have they might come back and say, well, they can apply to be in network. The problem is almost everyone's denied, and it's a very long process. It takes so much time, and it's just, you're in business for yourself. If you take 3 days to fill out a form and keep having to go back and talk to them, and then ultimately you're denied. I don't know. Amber can tell you how many hours she put into filling out these forms. And so far she's still been denied.
If I can, I want to answer from my perspective, Linda, your question about what, I know you asked Julia what she hopes to gain by getting the data. But if I can just offer my input, I think there are bigger system issues at play, and I understand that we need to do more with less. But I also feel like there has to be more that can be done on a local level to help these kids to create some kind of solution to and I'm talking about the kids because I don't want to get ahead of myself. I'll talk about that in my presentation actually. But I just feel like we need an actual accurate view of what's going on to motivate some change and to create some change. Right. So that's where I'm hoping that those numbers, if we have the accurate numbers, because I'm hoping that the accurate numbers will move people to action. So that's kind of my perspective on why that data matters to me, because these are real people. They're not just numbers. They're real people that are being harmed, and they live in our community, and they're often underserved. And so the conversation matters.
Okay, thanks.
Yep, it does. Okay,
And
any more comment?
Randy, I think somebody asked about how many private practice therapists are in this county. And another therapist tonight sat down, and we think there's 12 that see people in person that actually are located here, plus the number at Shoreline. And I don't know what the full-time equivalent is at Shoreline. They have many providers. Many are part-time, and they're all virtual. I think maybe they have now 1 or 2 that are in person. So that's not a lot of people to start with.
I just wanted to mention that Shira has joined now also.
Oh, good. Hi, Shira.
Yep, I just saw she
Hello.
just sent a message. Hi,
And she
Shira.
said
Do
Charlotte.
Finally.
you want to comment on this?
Oh, I was just adding that Shoreline has a certificate of approval, so they're in network with OHP with the CCOs.
Which is giving a number of therapists that are actually located here.
Gotcha.
Okay. Any more questions or comments? If not, we're going to move on. We're actually running out of time, kind of here. So we're going to move on to Amber Bowman's presentation. Amber, but I have to back that down some because we still have our provider reports to get to.
Yeah, no worries.
So,
I think I'll just kind of get through it real quickly, see if anybody wants to have a quick conversation about any points.
okay,
I
yes,
can
you got
definitely
the
just cut
floor.
it down. Can I get permission to share my screen?
Yes, sorry.
That's okay. I don't think you knew that I had a presentation, so it's all right.
Okay, there you go. You should be able to share it now.
Yep, perfect. Okay, and oh, hold on, it's asking me to grant access for something. I don't know what that means. Hopefully that wasn't the wrong thing to hit there. So the presentation that I'm hopefully able to share.
Not seeing it yet, Amber.
Not seeing it. Okay, let's see. Why is it not giving me permission? I feel like it's wanting me to like exit and then come back, like close. Oh no, here we go.
You may want to give it access to your computer. That may be the issue.
Yep, I just did. There we go. Thank you, Commissioner Thompson. All right, can you guys see my presentation?
Yes, we got it.
Okay. All right. So similar to Lisa's situation, I can't see you guys. So if somebody does have a question, if you guys can just hold it till the end or question or comment, because I do want to get through this quickly. The purpose of my presentation here is I was in a unique situation that I haven't been in before, where this last meeting I wasn't present because of issues related to my health. And that meant that I got to watch the meeting. And the great thing about watching the meeting is you can pause, you can rewind, you can, you're on the outside looking in and you just notice some things, right? And so I had asked Randy for permission to just kind of offer some feedback from some things that I noticed. And then I also just want to add some information that I wasn't there to give. So real quickly, something I've been struggling with, and I don't know about the rest of you, but I have been struggling recently with the role of the Human Services Advisory Committee, what my role is on the committee or on the council, what the council's role is. And so just starting off with, who are we? We are an advisory council meant to support the Board of County Commissioners on the 3 areas of developmental disabilities, mental health, and alcohol and drug abuse services. I will not read all of these, but these are, this is essentially what we're supposed to be doing as an advisory council. And this is based on, it's mandated, it's based on how the county describes the advisory committee or council, and then also that ORS. I think we can just get this sent out to everybody after the fact if we wanted to do that in an email. But I'll get to the next one. Sorry, I'm rushing through. This was one of the most important things that I wanted to bring up, is how are we having these conversations and how are people perhaps misunderstanding or maybe getting triggered, right? I feel like, especially with this care organ issue, there is for me at least, I'm a human being. I will admit that there are some emotions involved because I care greatly for the people that I serve in this county. And so one of the things that I noticed was some comments that had been made that were met with defensiveness or some information that was being brought up that wasn't relevant to what was being discussed. And so it feels like and this isn't the first time I've noticed this as part of the council. I've been on the council for a number of years, but it feels like when there is something that people feel passionate about advocating for, that other people might take that advocacy and feel defensive about it or attacked by it. And so I just wanted to bring attention to that. I don't want to call anybody out, but when I was watching the meeting, you know, there were people unmuting and chiming in when maybe they didn't necessarily need to. There were head nods that were very, like, and I worry that people might not be interpreting things the way that they're meant to be taken in these meetings, because we're meant to, again, our purpose, we're meant to advise the Board of Commissioners, right? And so these conversations are about what is happening in our county and what can we advise the commissioners to do, or what of our, our thoughts on how to support the people in our county in those 3 areas, right? Moving on, I'm almost done. This, I wanted to bring up, of course, the care organ situation. There was a comment that was made in the last meeting that I watched where someone had mentioned essentially these insurance changes, these policy changes by the CCO are what they are. And we have other things that are more important that we need to spend our time on. And that really stood out to me because this care organ situation, as I said before, I get that we have to do more with less, but to me, it doesn't feel like, it feels like we're talking in circles, right? About what's going on. There's not change. There's not a plan. And so I feel like until we really identify how we can help the people that are being harmed, the conversation should continue. I wanted to point out, and I'm glad that Shira and Amanda are both here, because when I watched the meeting, I heard how CBH is adding 2 adult therapists, and that's awesome. But again, I'm worried about the youth in our county. And I didn't hear any mention about what's being changed or done to meet that increased need. And so I wanted to just bring up, like, realistically, I'd love to talk about not just what's going on, but what can be done about it, right? How can we advise the county commissioners to support and help intervene to help these people that are being harmed? Here's my data. I wanted to provide this to everyone. So I took a look at how many adults on OHP I was serving, how many youth I was serving before the policy change. So you can see here, I was serving 14. The Care Oregon presentation said that there were 11 youth in our county that were being impacted, 11 total youth. I was seeing 14. 9 of those 14 youth have decided to continue seeing me, even though I can't bill their insurance. And what really moves me to feel some big feelings is that 5 of those 9, they qualify for my lowest reduced fee. And like Julia mentioned in the last meeting, as providers who have our own families we need to care for, and this is our own business, this is our livelihood, we have to make these decisions about allowing people to continue seeing us at a reduced rate, how that's going to impact us. Also, knowing that some of my clients, the $65 per visit, which is less than 50% of my rate, they can't afford that. I know that they can't afford that $65 per visit. And I know that their children or child needs weekly or bi-weekly, but we're only seeing once a month because that's all they can afford. So they're not even getting the care that they need and deserve. So this is from my experience, the picture that is like staring me in the face every day. This is the impact. These are the people that are being impacted by this change. Lastly, Sorry, lastly, I'm trying to hurry, Randy. Sorry. I just wanted to real quick point out something, set the record straight or add some context and clarify. As Julia mentioned, I have filled out so much paperwork. I have done so many things to try to get a contract with the CCO. There is the COA process, which is a certificate of approval, and that's through Oregon Health Authority. And if you have a COA, you're more likely to get a contract with the CCO. That COA process is for organizations that employ associate level providers, so not fully licensed providers. I don't have anyone working for me that has an associate level, so I don't need a COA. So the COA was mentioned, and one statement that was made was, for much time, folks in private practice have been able to be reimbursed for Medicaid without having to meet the same standards. And I just feel like it's really important to add some context to that, because the standards that I meet in my private practice, that all the other private practice folks in our county meet, are set by regulatory boards. And it's not about the COA and Oregon Health Authority, it's through the regulatory boards. We are upheld to the same standards. And the COA process, as I mentioned already, it's if you have associate level providers, so there is more risk, as if you will, if you have those providers working under you, but also a larger agency such as CBH. It makes sense for them to have all of those criteria, because they serve a higher volume of clients. They manage substantial public funding. They operate complex systems where policy, staffing, and quality decisions can significantly impact community outcomes. That's a big difference between a private practice that only has like one or two or three clinicians. So I just wanted to make sure to explain that there's a difference between standards and the COA process, which is the oversight. So I felt that was important to provide you guys. That is everything. So I don't know how much time we have, if we want to just spend 5 minutes, if anybody has questions.
Yep. Questions, comments?
I want to thank you all for letting me give that presentation. I was very nervous. I don't know if you could tell by my shaky voice. So I appreciate that you all let me share all that, because it did feel like a unique opportunity from the outside looking in, watching that meeting, for me to share those things.
Yep. Yep, I agree. Thank you. Shira.
Thanks. I just wanted to speak to the child and family piece, Amber, that you brought up. And I don't know why that didn't come up in the last meeting, but I do feel like I've talked about our capacity in kid services before within CBH. We have capacity to serve kids in our intensive in-home behavioral health treatment program, in wraparound, as well as just in regular outpatient services. So we have folks who can see kids currently. There's no wait list. Like, we have psychiatric space. Dr. Safai is our child psychiatrist, and she has plenty of room to see kids if they need medication management. So like, currently I haven't seen a huge influx of folks that are like coming to CBH like, hey, I lost my provider. Like, we need care from you guys. Of course, like if all of my clinicians were maxed out on their caseloads, like I would need to take a hard look at how I'm distributing resources within my organization, how I'm choosing to staff and prioritize community need. But currently CBH does have space. And I don't know, Amber, if I was
clinicians do you have? Sorry. How many
child
clinicians?
family clinicians do we have? That's a really good question. I think we have 5 full-time child and family clinicians currently.
Okay. I was told 4 by someone, but maybe it's because I heard that somebody might be leaving, and maybe hopefully they're not. I'm hoping.
I would have to check our org chart, Amber, to be completely honest. Like, we are a pretty complex organization, like you said. So, I think between 4 and 5 full-time family clinicians, but I can get you all that that number after I check our org chart. And then the other piece was, I don't know if I was the person that had made the comment about private practice standards, and I appreciate the importance of language and semantics. I think my point around that was more rule oriented, and the 309s that CMHPs are held to, and the documentation expectations that CMHPs are held to, and COA organizations are pretty different from folks in private practice, and that's been historically true for quite some time. But I appreciate the clarification and the conversation there too.
And I do,
Yeah,
and I do want to point out too, oh, sorry, Randy. I
No,
do
go
know
ahead. I
two
was gonna say,
factors. Yeah, I know two
Go ahead.
factors. You know, Shira, you had mentioned that you're not seeing an influx. And first of all, my first thought is, well, a lot of them are choosing to stay with their providers and opt out of insurance and pay out of pocket, even though they can't afford it, right? Like, at least in my experience, I'm seeing a big number of people doing that. But also something that is not CBH's fault, but it is the nature of the system, is when you have community mental health, you have providers, you have high turnover. And so
We don't actually. Our turnover rate is really, really low. Our vacancy rate is really low, and our turnover rate is actually pretty low too.
So if I may finish real quick, I have had personal conversations with families who have said when they were at CBH, their child had 2, 3 different providers while they were there. So the anecdotal, qualitative information that I'm getting is people don't want to go to CBH because they feel, their perception is that there's high turnover. Their perception is that they've had an experience maybe where they've had multiple providers. They've established trust and rapport, the foundation of a therapeutic relationship and therapy, and they don't want to go into a situation where they have to start all over again, and then probably from their perception, again, their perception, that they will have to switch to a different provider. So that is just, and like I said, that is not CBH's fault. That is just the nature of community mental health. And I'm really happy to hear that CBH doesn't have high turnover. But
And I
that is
think
the perception.
And I think it's all relative too, right? Like when I say we don't have high turnover, I'm talking about our comparatively to community mental health programs and like large behavioral health organizations across the state. That's obviously going to be really different when someone's like, they're engaged in private practice and you have one person and there's not going to be turnover there. Like they're a reliable person and there isn't really turnover there, right? Unless they like move or leave or something like that. So of course, the turnover rate that's going to be experienced in a community mental health program will inherently be higher, and just to say again, like, and as I said in the last meeting too, like CBH really values our private practice partners. Like, I think, we need a network of people in this community. I know CBH, we do civil commitment and we put people on holds, and we play a role in the community that can sometimes impact whether someone feels like they want to continue receiving care from us, right? We have to make hard decisions. And so it's really important that folks have the option to choose and, have some variety in their provider selections. And so I think that folks in private practice, we really value them. And again, this of course is not our policy decision. I just wanted to highlight that, we're responding in the way that we can best respond. We're trying to staff up in the ways that we can staff up. We do have capacity to take folks if they want to receive care from CBH. Yeah.
Okay. Amber, your care for your clients is admirable, and thanks for your input on this. I appreciate it. And any more questions or comments? Otherwise, we're good. And we still have some reports to get to. Commissioner Thompson.
I just want to say how grateful I am that people who care about caring for people and what that looks like and sounds like, and the hard pieces and the easier pieces are coming together to talk, to have these conversations so that you can unite and we have this whole continuum of care in the county. I'm so grateful for everybody who's providing this care. Thank you.
Agreed.
Brandy,
Okay, let's move on. Oh, go ahead.
may I just like, and I think I brought this up in the last meeting too, but I just think it's important to center this conversation, or at least maybe not center, but maybe place this conversation in the larger context of what is happening in Oregon and the publicly funded sector. And that is, again, that CCOs throughout the state are underwater, are in financial crisis. There are program closures happening throughout Oregon, and different behavioral health programs are closing. One CCO actually pulled out of an entire region, and that was specific source. And so that also means that like that's going to have an impact on rates and resources, right? We're in a scarcity climate right now, in a time of retrenchment. And so there are just really difficult decisions that network managers, the CCOs, are having to make around how to prioritize care and funding, and how to make sure that care is available to as many people as possible while they're directing finite resources and trying to support safety net services as well. In addition, the state is like gearing up for really, really significant Medicaid cuts and reductions that we will see happening in the coming years, up to potentially 40% of folks who are currently on Medicaid losing their health insurance. So I don't want to take the importance out of your conversation, Amber, and I want for this council to see we are in crisis. Like, this is a financial crisis. The publicly funded system, it will crumble if we can't figure out how to hold it together and how to come together as a community. And I would ask that this council consider spending some time and energy in talking about ways to pool resources to help Medicaid members keep their insurance, to meet the enrollment expectations, to meet the workload requirements. Like, those conversations feel really pressing to me. And so I feel like the move for the CCOs to move to a closed network, and I'm not going to speak on behalf of the CCOs, but my impression, this is a financial reaction. They cannot afford to pay everyone. That's the reality of the situation. That's the reality of the climate that we're in. And so I just want to bring that into this room and just really encourage us to think about ways to really focus our attention on ensuring that our community members maintain their health insurance, because that's going to be an access issue unlike anything we've seen before.
Okay. Thanks, Shriver. I have to move. I have to get this moving on here. We're running out of time. This is a hot topic, and I'm sure we're going to come back and discuss this again in the near future. So thanks, Amber. Appreciate it. And let's move on to CBH. Shira, do you have anything for us?
Yes, due to significant funding reductions, in the same vein that I was just kind of speaking to, CBH had to close our South County shelter. We were operating a 5-bed shelter in Seaside that will close as of November 9th. We were able to find housing options for all of the folks that were staying in that shelter, and I'm able to retain all of my staff, which is awesome because we're about to open Baker Building. So we're able to just shift some employees around, but that is a resource that we'll be losing. In addition, we've had a pharmacy located at our Bond Street clinic, Genoa, and due to their own business decisions and challenges, they've decided that they have to pull their pharmacy from our clinic as well. So that's a really significant resource that we've had within CBH that will be greatly missed, but we'll have operations with Genoa through January. In better news, we're excited about Baker Building, and things are moving forward, and we're still set to open end of December, and we have a list of folks who are excited about moving into that space, and it's just beautiful. Like, the units are amazing. They're big windows that overlook the river and the Megler Bridge, and I, for one, love that this is low income permanent supported housing with a view, because that, as we all know, that doesn't always happen. So I just think it's going to be such an asset for the community, and we're excited to see the impact that it has on our housing crisis.
Okay, thanks, Shira. Hey, a quick question for you. Now that you're moving out of there.
Sorry, you cut out a little bit. Say that again.
I know I got some internet issues going on over here. What's going to happen to your building there on Broadway?
Well, so to be clear, we're still there. We have a clinic there. We have a rapid access clinic there on Broadway. We have
Okay.
some apartments there that are still ours. There's one building that is ours that has been operating as a shelter. And I don't know what we're going to do with it yet. We're going to just pause throughout the remainder of the year and focus our attention on opening Baker Building and then decide what we're going to do with that space. Hopefully in the future, open a shelter again. But currently that's not an option for us. So stay tuned.
Okay, great, thanks. Any comments or questions for Shira before I move on? Okay, thanks, Shira. Commissioner report, Commissioner Thompson.
Skip me today. I don't have anything that's so important that you haven't already heard from me. I keep working on stuff. I'll let you know what I'm doing, when I'm doing it, how I can use help, how I can give help later.
All right. Appreciate you being here. Thank you. County management report, Monica.
Thanks. I'll just give a quick update that we did get our contracts with OHCS, and so therefore we have done our contracts with our subrecipients for the shelters that we have throughout the county, and so those are for CCA, Lifeboat Services, Helping Hands, and the Harbor to maintain the shelter beds that were created under House Bill 5019, as well as the prior shelters, the shelters that existed prior to that, the maintenance portion of that. So that goes back to July 1. So that funding is for through this calendar or this fiscal year through June 30th of 2026. And the county is in the process of applying for being the regional coordinator for the statewide shelter program for our county. And so that would then be looking at the shelter funding for future years. So happy to answer any questions.
Did I lose Monica?
Did
No.
nobody hear my report?
Oh, I did. Okay, I got you
Oh.
back. I just lost you there for a second. I'm having
Oh,
internet
okay.
issues over here. Okay, thanks, Monica. Any questions or comments for Monica? If not, we'll move on to public health report and Jill.
Hi, thanks. Hopefully folks have heard by now, the governor has declared a hunger emergency. Public health has been working with our emergency management department with Clatsop Community Action and others in the community to identify food resources, food banks that are affiliated and non-affiliated with Oregon Food Bank. WIC continues to operate as usual. Today we received the official notice that the Oregon WIC program will have full November payments and that will cover WIC agencies and estimated food costs through at least the end of November. So we are still encouraging and messaging that WIC is business as usual, and for families with children under five and under to use WIC and see if they call WIC and see if they meet the eligibility requirements. And then the community health needs assessment is also complete. So we will be at some point looking at our communications plan for that, similar to our youth prevention needs assessment, bringing it out to the community. We'll be sharing feedback with you. Again, that assessment was done in partnership with Columbia Memorial Hospital and Providence Seaside. And then we'll be working with the Rural Health Coalition, which both hospitals as well as community partners are a part of, to work on our community health improvement plan. And that's my really quick update. Any questions?
Great, thank you. Amber.
Yeah, I have a quick question for you, Jill. Will the Public Health Department be applying for any grants through Oregon Health Authority that I can't remember what the name of the grant was that they released, but
No, I
no.
think that at the state level, there's work being done around that, but no, public health won't be.
Okay, all right, thank you.
Okay, thanks, Jill. Let's move on to Lisa.
I just wanted to remind you guys that we have kicked off our data capacity assessment. We've been doing key informant interviews, and we plan to get all of your feedback on what kind of data and information, which we talked a little bit about during this meeting, you might need in order to do your work and advocate and advise the Board of County Commissioners. Specifically, we're looking at substance use data, and that's across, since we were just talking about it earlier, the whole continuum of care substance use data, from health promotion to prevention to treatment to recovery, of what our community might need, and what we already have potentially. I expect that to usually those take about an hour, and our contractor, I'm not sure if it'll be Heidi or Carmen, but it's our same contractor who did the youth prevention needs assessment who will be doing that data capacity assessment with us and doing the focus group. I was hoping to spend maybe 5 minutes at the beginning of that, because by then I can have sent out the youth prevention needs assessment, the full assessment document, to get your feedback on that as we move into kind of making our priorities for our planning process. But I can put that off to another meeting as well if we wanted to, because I know you, Amber, you were saying that maybe we should talk about this more, coming up with strategies. And so if we're doing an hour for the data capacity assessment, and then that will take time as well. I just want to make sure I understand what the agenda should look like for next meeting, I guess, is my question.
I would say let's put that on for January. Because I know
the youth prevention needs, or the talking about options for supporting mental health.
They're talking about the options.
Okay.
Yeah. Because this next meeting is going to take up the focus group is going to take up the whole, pretty much the whole meeting, it sounds like. Yeah. And so on our next meeting, it's probably, we're not going to be doing provider reports. We're just going to be focusing on this data capacity assessment from Lisa. Is that my understanding?
Yeah, if that sounds good to you guys.
Sounds good.
Good, then I will work on that. And that is my main update. We will be at the Emergency Community Food Swap and Pantry Stock event on November 23rd from 10 a.m. to 2. That's Sunday, as part of the Community Health Advocacy and Resource Team and Public Health, to support that volunteer run event, as well as a community resource.
Okay. Any questions for Lisa? If not, we're going to go. Oh, go ahead.
Well, I don't know if you were going to do a good of the order, and Lisa's comments just reminded me. So if you are interested, there's lots of places that you can, but Clatsop County is doing a food drive for the food bank. And so there are facilities throughout the county, all of our buildings. It's a competition between buildings. And so if you want to drop something off, you can drop it off at 800 Exchange. And that way we'll get the credit. Just kidding, to public health. But it is a competition between who brings in the most, as well as who submits the most complete meal. So that way, when putting things together, it's a whole meal that is kind of creative, that's getting donated. So just another place that you can donate if you're looking to.
Great. Thanks, Monica. Yeah, I was going to get to the good order that was coming up, but thanks for the info. That's good to know. Okay, so the next proposed meeting is December 4th at 3 p.m. with Lisa's data capacity assessment. And Monica provided good of the order. Anybody else with anything for good of the order?
I have
If
one more
not-
update. Sorry, if you
Okay.
don't mind. Just within ODDS and Developmental Disability Services, the state has taken back the responsibility of licensing foster home providers within the county, and they've done that across the state. So that obviously means that it's a pretty significant funding reduction for our local CDDP. It also means that local developmental disabilities, DD and IDD providers are not going to get the boots on the ground, face-to-face, community-based supports in meeting licensure expectations and requirements. They'll have to do that through ODDS moving forward. So I just wanted to share that that's a pretty significant like structural change within the DD service system.
Great, good information. Okay, thank you. And it is 4:31. It was another good, healthy, and productive conversations we had here, and I appreciate